Hi everyone. So let's go ahead and finish up this section. We're still on section 3, and we were taking a look at the formed elements that are going to be found in the blood. We've already talked about hemopoiesis, and we talked about erythrocytes. So now we're going to conclude by talking about leukocytes and platelets, which are the last two formed elements that we need to talk about. So let's first start off with leukocytes. We'll briefly talk about leukocytes here because we're going to talk a little bit more about them when we get to the immune system, because that is one of their main functions, is to help defend the body against pathogens. And really, depending on what leukocytes we're looking at is going to depend on what pathogen they are going to go in and destroy. So let's compare them to erythrocytes. Remember, erythrocytes were full of hemoglobin, they had no nucleus, they had no cellular organelles. Well, it's the complete opposite here with the leukocytes. They are going to have a nucleus, they are going to have cellular organelles, and they are not going to have any kind of hemoglobin. So remember that the erythrocytes are actually, they spend their lives in the bloodstream. They are constantly moving around and picking up oxygen and going and dumping off oxygen. That's not the case for leukocytes here. Most are actually not found in the blood. They're found in different lymphatic tissues and organs. So they kind of hang out there and stay there until there is a need for them. And once there is a need for them, then they enter the bloodstream, they get to where they need to go. And then once they get to where they need to go, they are going to leave the bloodstream and enter that way. So we'll take a look at maybe one of the leukocytes in the immune system that's a little bit different. But for the most part, that's how they are going to, that's a big characteristic about them. Let's take a look at it, how they are going to kind of squeeze through the endothelial cells right here of the blood vessel. Look at that. That is called diapedesis. And there's that word right there, is that squeezing from the capillary through the cells into the tissue that they need to go to. So you might be thinking, well, how do they know where they need to be? Because there's a lot of different tissues, and we want to make sure that they get to the tissue that's infected. The way that they know is by these molecules that the damaged cells and pathogens are going to release. And once those damaged cells and pathogens release these molecules, the leukocytes kind of can smell them. I don't want to use the word smell, that's why I use my quotes, but they are attracted to the molecules, and that is called chemotaxis. It's a positive chemotaxis, and that's how they know where they are going to be. So let's go ahead and take a look at the 5 major leukocytes. And once we get into the immune system, we'll take a look at some of the subcategories of some of these leukocytes. But they are going to be divided up into 2 distinguishable classes, and it's mainly going in and looking at these granules or these secretory vesicles that are found in their cytoplasm. So you have granulocytes, and the top portion of this chart right here, these are going to be our granulocytes. And the granulocytes, because of the fact that they are going to have these visible granules that really do go in and distinguish them from each other. And you can see them on a light microscope, these different granules. So you have your neutrophils, you have your eosinophils, and you have your basophils that are going to be granulocytes. And then the other ones here on the bottom, the other 2 are going to be our agranulocytes. They're going to have either really, really small granules that you can't see on light microscopes or no granules. And these, there's the lymphocyte and there is the monocyte. Let's think back at leukopoiesis whenever we talked about that, and let's talk about the stem cell lines that they are going to originate from. Remember that this lymphocyte is going to come from that lymphoid stem cell line. And then everything else, the other 4, actually came from that myeloid stem cell line. All right, so let's take a look at them a little bit more by going in and looking at their characteristics and their functions. For the approximate percent, we're actually going to talk about that in a little bit when we look at the differential white blood cell counts. So let's just kind of, we'll look at this table a little bit later on. All right, so let's look first at the different granulocytes, and we're going to start by looking at this thing called the neutrophil. So this guy right here is going to be a neutrophil. A neutrophil, the way that you can, identify a neutrophil, it is going to be from its multi-lobes. Usually it has 3 to 5 lobes. Look, there's a lobe, here's a lobe, here's a lobe. So I kind of say that it has kind of a funky nucleus, and that's exactly what's going on here. Look at the granules. You can kind of see those granules all around. If we go back and take a look at the actual microscope picture, there's the microscope picture of it. You can see the multi-lobes in there. You can even see the granules as well. So neutrophils are usually going to be the first ones on the scene, very, very active phagocytes, especially bacteria. They absolutely love bacteria. So really, if you have a bacterial infection, you are going to see an increase in your neutrophils because of the bacteria and them going and trying to, of course, get all of the bacteria and destroy all the bacteria. Now let's move on to the eosinophils. The eosinophils, there's 2 things that are characteristic of an eosinophil when you're trying to identify it. And that is going to be the fact that it has a bilobed nucleus, see here and here. And then it has these kind of reddish to hot pink granules as well. And no other white blood cell is going to stain that way. So go back and let's take a look at it right here. So see how it's kind of, this gives it more of a I don't know, fuchsia color, but usually when you see it under a microscope, it's going to be a little bit more of these red granules. So a little bit better red coloration than this picture is giving it. So these eosinophils are interesting because not only can they phagocytize, and usually they go in and phagocytize these antigen antibody complexes, they're also very active in phagocytizing allergens as well. So some individuals, if they do have some kind of allergic reaction, they are going to have high eosinophil counts. Another thing that they can do is they can actually release some of these granules, some of these chemical mediators found in these the vesicles, and they are going to specifically target parasitic worms. So if you have some kind of parasitic worm infection, then again, you might have a high eosinophil count because of that. All right, let's move on to our basophils. Here is the basophil. The basophil is characteristic mainly because of the fact that it has these super dark, bluish, dark purple granules, and sometimes they are so dark that you can't even see the nucleus in it. So let's go back and take a look. Look at this. You really can't see a nucleus in there at all because it has such, it has all of these blue and purple granules that are going to show up. Let's talk about what's in those granules. They are going to be histamine and they are going to be heparin. So anytime that we have this kind of inflammatory reaction that's occurring in our body, it's because of our basophils. And also we'll talk about mast cells and the immune system as well. But basophils are going to kind of create this inflammatory reaction. What the histamine does, it's a vasodilator. So it is, of course, going to open up those blood vessels. And it also causes the capillaries to be a little bit leaky as well. So it can cause some tissue edema. What heparin does is it is going to be an anticoagulant. So these are going to come more into play when we get into the immune system. So let's take a look at those later on in a couple of chapters away. All right, let's get to our agranulocytes. So let's talk about the first one. The first agranulocyte is this one right here, and that is our lymphocyte. Once we get into the immune system, we'll talk about the different lymphocytes, like the T lymphocytes and B lymphocytes. But for now, let's just look at them as a lymphocyte. They are going to be really important in more specific immune cell responses. They're the ones, one of these specific types of lymphocytes are going to produce antibodies. They go in and attack pathogens, infected cells, abnormal cells. So they have a lot of different roles. So as far as characteristics, look at that big, nice, giant, round nucleus. That's how you can tell a lymphocyte. And it's always going to have a little bit of cytoplasm. Well, I like to call it a halo of cytoplasm surrounding the nucleus. So if we go back and take a look, here it is. So you see that nice, really dark purple nucleus and a nice, I know I keep saying nice over and over again because it's a really beautiful cell right there. There's the halo of cytoplasm. Don't get it confused with this basophil. Do you see how the basophil, you can see obvious little granules in that basophil. You can't see a nice cytoplasm that's surrounding a nucleus. So that's how you can tell the difference between the two on a microscope, because you will have to do that for your quiz. So make sure you are able to do that. Last but not least is the monocyte, the big giant leukocyte, the biggest of them all. Characteristic is, of course, their giantness, their largeness, but they're also going to have this kind of kidney bean or C-shaped nucleus. And if we go back over here, this is not a great picture of a C-shaped nucleus, right? I kind of want to extend it a little bit. Let me see if it'll let me make it a little bit better. Oh, that's much better nucleus right there, right? So that one's a little bit tricky that they showed you. This is a lot better right there. But you're going to have that type of nucleus right there. What they do is they are going to, once they get into the bloodstream, they'll travel to where they need to go. And then once they exit the bloodstream, they become macrophages. Macro meaning, of course, large. Phage meaning eater. And really, they are going to eat anything that they can find. Bacteria, viruses, old red blood cells. Remember we talked about that. Debris, cellular fragments. You know, they're garbage men. They like to go up and just kind of clean the area up. So those are your leukocytes there. And again, we'll look at them once we get to the immune system a little bit more, especially those lymphocytes we'll talk about more in the immune system, especially those basophil. Actually, all of them we'll talk about in the immune system. So let's take a look and see what kind of pathological conditions can come about whenever there is abnormal amounts of leukocytes. So we're going to be talking about, we're just going to mention, actually these are just kind of going in and looking at definitions. So leukopenia is going to be when you have a reduced number of leukocytes. And think about what happens if you have a reduced number of leukocytes. Yeah, you have a higher risk of becoming infected with some kind of pathogen. Leukocytosis. So these should be keywords at the very end. That's kind of telling you what's going on. An elevated amount of leukocytes. Sorry. So this is kind of talking about what might cause leukocytosis. Leukocytosis can be caused, of course, by a recent infection. If you do get an infection, then a lot of times, you know, if it's a bacterial infection, you'll have more of the neutrophils. If it's a parasitic worm infection, you'll have more eosinophils. But stress can also cause an elevated white blood cell count as well. And stress can sometimes cause a decrease in white blood cell count. So it's kind of interesting how stress can cause both. Because remember we talked about in chapter 17 how chronic stress can actually reduce the amount of white blood cells in your immune response. So it's kind of interesting how stress can go either way. So the way that doctors can go in and use the amount of white blood cells that you have, the different kinds of white blood cells that you have for clinical diagnoses, is doing something called a differential count or a differential white blood cell count. What this does, it just kind of gives you a range or percentage of all the different white blood cells in the that is in your differential count. And it can kind of give them an idea of what might be going on in the body. So let's go back to this chart. And remember that there were these approximate numbers over here. So the way that I remember which one's the most abundant to which one is the least abundant is never let monkeys, well, it did not like my monkeys, did it? Monkeys eat bananas. So your neutrophils are going to be the most abundant of all of the leukocytes, as you can see, followed by lymphocytes, followed by monocytes, followed by eosinophils, and then basophils. So anytime this number goes up or it goes down, it gives the doctor a really good idea of what's going on. So let's say, oh, wow, they have a lot of neutrophils in their bloodstream. An increased amount of neutrophils is going to be neutrophilia. And usually it's some kind of bacterial infection. But again, it can be stress. It can be with tissue necrosis. If you think about it, you probably still have a lot of bacteria in the necrotic tissue. So that can be some of the issues there. So some immature neutrophils can entering will count as well. So that makes the body seem like they have a lot more neutrophils when they're immature and they really can't do anything. Let's take a look at what happens when you have a decreased amount of neutrophils. That's neutropenia, and that's going to be a decreased amount. That can happen with anemia. Drugs, radiation can actually go in and cause a decreased amount of neutrophils. So let's talk about eosinophils. Eosinophils, remember, they were ones that they go in and phagocytize allergens, and they go in and release chemicals to help kill off parasites. So eosinophil numbers understandably are going to increase anytime that you have an allergic reaction. If you have parasites, or some autoimmune diseases will actually cause an increase in eosinophils. What about those monocytes? What do you think about those monocytes? They can increase if you have chronic inflammation or tuberculosis, and they can decrease because of prednisone therapy, which is really, really interesting. If you think about it, think about what prednisone is. It is a steroid that some people use to help with inflammation. So remember, one thing that we talked about with cortisol is that cortisol is also a steroid hormone that goes in and reduces inflammation. It does it by destroying some of these white blood cells. And that's similar to what prednisone does, is going in and killing off some of the white blood cells, which here specifically would be monocytes. Now let's take a look at basophils. So basophils can change or increase, I guess I should say, in response to this myeloproliferative diseases. And basically, if you think about where that's coming from, we talked about myeloid stem cells, which is going to be found inside of the bone marrow. So that's going to be where you have an overproduction of these from the bone marrow. But it is also going to decrease in response to acute allergies and also stress reactions. And lymphocytosis, again, there's that cytosis. This is an increased number of lymphocytes. It can be because of viral infection, chronic bacterial infection. We'll talk about leukemia here in a minute. And then some cancers of plasma cells. Plasma cells are a very specific type of lymphocyte that we are going to look at in the immune system. So that can cause an increased number of lymphocytes. And then you have lymphocytopenia, and again, there's that penia word. A decreased lymphocyte count can be caused by HIV. We'll get into that more in the immune system. Again, other leukemias. So it's interesting how some leukemias will cause an increase, but then some will cause a decrease. There's so many different types of leukemias, and we'll talk about just broad categories of some next. But because of that, they do manifest in very different characteristics sometimes. And sepsis can also cause a decreased lymphocyte count. So now let's go ahead and take a look at leukemia. So leukemia is going to be where you have this malignancy and leukocyte forming cells. It's going to stem from the bone marrow. And if you know anyone with leukemia, then sometimes some form might need a bone marrow transplant. So that's one thing that we need to kind of back up and talk about, is there are several different types of leukemia, and unfortunately, we don't have time to talk about all of the different types of leukemia. But the main thing to know about leukemia in general is that it comes from those leukocyte forming cells in the bone marrow. So it's coming from like the myeloid stem cell line or the lymphoid stem cell line. We talked about those two, so it could come from those two. What happens is that you have an abnormal development and proliferation of leukocytes from whichever line that it's going to come from. So because of that, it's spitting out all of these, the red bone marrow is putting out all of these abnormal leukocytes. So, but they're immature leukocytes. When I say immature, I mean they can't function correctly. So you have all of these leukocytes taking up space in the, they're taking up space in the red bone marrow and then, of course, in other tissues. And then what happens is the fact that they really aren't doing their job. So an individual might be with leukemia can get several infections, and then the people might think, well, I don't understand. Whenever it looks like I have a high leukocyte number or a high white blood cell count. And the reason why it looks like that is because you have all of these immature leukocytes that are going to be found either in the bloodstream or in the red bone marrow or in the lymphatic tissues. Another problem that it causes is because it's going out, those stem cells are producing so many of these abnormal leukocytes, the erythrocytes and megakaryocytes that they produce are going to lower. So they're not producing as many erythrocytes and they're not producing as many platelets. And that is going to, of course, cause anemia because of the fact that there's not enough red blood cells that are being produced. And it's also going to cause a problem with bleeding because you don't have as many platelets that are going to be produced as well. So let's just take a look at two general types of leukemia, just acute and chronic leukemia. As far as acute leukemia, this is going to be the one that where it's going to show rapid progression. That's what the acute is going to come from. And death occurs very quickly, and it really just depends on the age of the individual. It can occur very quickly if it's children or young adults. And then there is a chronic leukemia, is a slower progression, and this is going to occur more in middle-aged or older adults. But with both of these leukemia, acute and chronic, you get the symptoms like anemia, chronic infections, and bleeding disorders. So speaking of bleeding disorders, that actually leads us over to the very last formed element. And again, we've talked about how different these formed elements are from the red blood cell that doesn't have a nucleus, it doesn't have organelles, it's full of hemoglobin, to leukocytes that are going to have a nucleus, are going to have organelles, don't have hemoglobin, to platelets. Platelets aren't even a true cell. They are little cellular fragments from that megakaryocyte. So they do not have a nucleus. They're very tiny. Remember looking at them under the blood smear. They're very small. Another term for them are thrombocytes, which is not often used because this makes you think it's a true cell when it's not. Now, other animals actually do have platelets that have a cell, which is very interesting. But ours is a little bit different. So their main thing is that they're going to play a role in blood clotting, which is what we are going to look at in section 4. Most, or about 30% of platelets are going to be stored in the spleen. What they do is they are going to circulate for about 8 to 10 days, and then they are broken down and they can be recycled after that. So they don't live very long at all. I didn't talk a whole lot about how long white blood cells live, mainly because of the fact that they're all very different. You know, some of them, a lot of them aren't going to last very long, but some of them can last for years. It just depends on the leukocyte. So that is a platelet, or platelets, I guess I should say. And so the next section, we're going to expand on this whole idea of platelets. We're going to be taking a look at platelets. We're going to be taking a look at fibrinogen, which is one of those plasma proteins that we mentioned long ago in a previous video. And we're also going to be taking a look at other clotting factors and calcium and the importance that they play in this thing called hemostasis. So until then.